friends, welcome back to Lomedics. This lecture is on preterm labor. Content of the video: introduction, causes, pathogenesis, prediction of preterm labor and treatment of preterm labor. Full term means 39 weeks to 40 weeks plus 6 days. If early term means 37 weeks to 38 weeks plus 6 days. If the labor is start before 37 week means that is preterm labor. Effacement means thinning of cervix, that is effacement. Preterm labor means regular painful uterine contraction associated with effacement and dilation of cervix occur after 20 weeks of gestation, that is preterm labor. Causes of preterm labor are maternal characters, maternal systemic disease, maternal infection, uterine factors, obstetric history, pregnancy complication. These are the causes of preterm labor. First, maternal characters: low or high maternal age, poor economic status, high physical work, and cigarette smoking, usage of drug, cocaine and alcohol. These are causes of the preterm labor. Maternal systemic disease: they are renal disease, hypertensive disease, maternal diabetes, immunological disorder like SLE and antiphospholipid syndrome. These are causes of preterm labor. Maternal infections: they are febrile illness like malaria, infectious disease like syphilis and toxoplasmosis, chorioamniotitis, bacteriovaginosis. These are causes of preterm labor. Uterine factors are uterine malformation, unicornuate, which means single side uterus, dicornuate, the uterus is divided into two, and septate uterus. Cavity of uterus is separated by septum, that is septate uterus. Cervical incompetence and obstetric history like previous spontaneous preterm labor and recurrent abortion, and pregnancy complication like threatened abortion, multiple pregnancy, hydramnios and placenta previa. These are causes of the preterm labor. How they are causes of preterm labor? First, decidua and fetal membrane. These are the site of synthesis of prostaglandin. Prostaglandins are considered to be an important agent in spontaneous labor and delivery. During uterine infection, hemorrhage or some other causes that stimulate the synthesis of progesterone. So, the progesterone level is increased, that causes the preterm labor. How to predict the preterm labor? By ultrasound, measuring the cervical length. At 24 weeks, the mean cervical length is 34 mm. If the preterm labor start means the cervical length is reduced to less than 25 mm. That indicate the preterm labor, and cervical funneling is present, which means U-shaped cervix, that indicate the preterm labor. This is the U-shaped funneling of cervix, and the cervical length is reduced to less than 25 mm. And biochemical test in cervicovaginal secretion, increased fetal fibronectin level is present, which means the fibronectin present between the fetal membrane and the maternal membrane. If the separation between the membranes are causes the labor. So, the fibronectin present in the cervicovaginal secretion, and uterine contraction occurring at a frequency of 4 times in 20 minutes or 8 times in 60 minutes with cervical changes, and cervical dilation is more than 1 mm, and then cervical effacement is achieved 80% or greater than 80%. How to manage the preterm labor? Based on the membrane. One is preterm labor with intact membrane, another one is preterm labor with ruptured membrane. If the preterm labor with intact membrane and the gestational age is less than 34 weeks means we can delay the delivery. Administration of corticosteroid to mother to improve the fetal maturity. 2 doses of 12 mg betamethasone IM 24 hours apart, and then 4 doses of 6 mg dexamethasone IM every 12 hours. These corticosteroids improve the fetal maturity. And then tocolytic agent. These agents inhibit the preterm labor. Example: beta-adrenergic agent, Intrauterine, salbutamol, terbutaline. These are inhibit the uterine contraction, and it has some side effects. They are hypotension, tachycardia or palpitation. And other tocolytic agents are magnesium sulfate that alternate the myometrial contractility, and it is used in insulin-dependent diabetes mellitus patient. And then prostaglandin inhibitors like indomethacin and aspirin. These agents inhibit the synthesis of prostaglandin, but it has some side effects. They are premature closure of patent ductus arteriosus and neonatal pulmonary hypertension. Calcium channel blocker like nifedipine, it reduces the calcium concentration and inhibit the uterine contraction. It is the preferable drug due to less side effect. And then nitroglycerin transdermal patch, it is safe and effective tocolytic agent, and oxytocin receptor antagonist. Oxytocin that increase the uterine contraction. If we give the oxytocin receptor antagonist means It reduces the uterine contraction, that is Pathogenesis. Indication of tocolytics are, if these criteria are present, means we can give the tocolytics to delay the labor. The conditions are gestational age less than 37 weeks, cervical dilation less than 3 cm, no history of unclean vaginal examination, no evidence of chorioamniotitis, no pregnancy complication like preeclampsia and antepartum hemorrhage, normal alive fetus with no distress. These are necessary to give the tocolytic agent. If the preterm labor with ruptured membrane means inhibition of labor is controversial, and we can give the corticosteroids to improve the fetal maturity in 24 to 48 hours and then delay the delivery by using for short period only. Thanks for watching.